into the actual treatment. First, we're going to have Dr. Gooding discuss with us the treatment approaches. Dr. Gooding is an assistant clinical professor at the University of California, San Diego, and Veterans Administration Medical Center. He is a reviewer of the Journal of Vascular and Interventional Radiology and has recognition as a distinguished reviewer for that journal. Dr. Gooding is a co-investigator with the San Diego Cardiac and Vascular Institute and has published his results. Dr. Gooding was Chief of Interventional Radiology at Scripps Memorial Hospital in Chula Vista prior to joining North County Radiology. He is one of the 3 IRs performing venous angioplasty as part of the Hubbard CCSVI study in San Diego.
I think my talk is shorter than my introduction. I'll start off the talk with a disclaimer from H.L. Mencken, who was a prominent cigar-smoking, old-time political commentator. He said, "Penetrating so many secrets, we cease to believe in the unknowable, but there it sits nevertheless, calmly licking its chops." As doctors, we sort of like to see ourselves as the experts and as having all the answers, but CCSVI clearly challenges us on this issue. We don't have all the answers. We think we're on the right track, but we have a lot of work to do. The history of CCSVI, you've seen some of this already. It goes back to 1863 when Rindelfleisch noted that these MS lesions were located in a periventricular location. And then there was radio silence for about 150 years until Zamboni kind of extrapolated this to the actual treatment of venous disorders in trying to make these MS lesions resolve or disappear. This started a social media frenzy, which came close to toppling the Canadian government, or may still get. A few studies were performed in 2010, 2011 with some variable results. We started doing this about a year ago and have since done approximately 300 patients under an IRB protocol. And currently CCSVI procedures are being performed in 40 countries across the globe, but not Canada. The pathophysiology, Dr. Dates talked about this somewhat. Basically, a localized venous hypertension that causes delayed perfusion, hypoxia, and increased transmural pressure within the veins that breaks down the blood-brain barrier, causes hemosiderin deposition, and subsequent myelin degeneration. And that results in these characteristic periventricular MS plaques. If that sounds familiar, it's because we've seen this all before with respect to the lower extremities. The pathophysiology of venous stasis in the legs is venous hypertension, localized elevation of venous pressure, causing tissue anoxia, inflammation, hemosiderin deposition, and necrosis. What does this mean to patients? Basically, they come in with really ugly, diseased legs. They tend to have a lot of swelling, they have hair loss, skin thickening, they get discoloration from the hemosiderin, they get breakdown of the skin, and ulceration. And if this isn't treated, it can actually lead to amputation. In the legs, the etiology of venous stasis can be due to occlusion of the deep veins, but it can also be due to abnormal valves in the superficial veins. And in this case here, a patient with severe venous varicosities. The patient also had abnormal flow, reverse flow in the superficial veins. Patient had endovenous laser treatment with burning the superficial veins, sclerotherapy to eliminate the superficial varicosities, and after we're done, you see there's a nice result, a nice cosmetic result at least. Patients like this with ulcers frequently present with the same underlying issue, and when you treat their veins, the ulcers go from looking like this to looking like this. The ulcer disappears, the skin heals, and gradually new skin sort of takes over for the old skin. The CNS is obviously a lot more sensitive to everything than the leg is, but the fact that these changes occur in the leg, it's not that broad a jump to extrapolate that to the central nervous system. I would argue that most neurologists have never seen a venous ulcer, so it's a little bit harder for them, I think, to make that leap of faith. But for people that see these things and treat them and see them disappear after the treatment, it seems a lot more sensible. Basic venous anatomy of the head and neck, it can be as complicated or as simple as you want. Basically, millions of tiny little venules coalesce into these sinuses, the suprasagittal sinus, the transverse sinuses, the sigmoid sinuses. Those dump into the internal jugular veins. You have the external jugular veins on the outside, and then a vast array of vertebral veins. Getting back to a question Dr. Hubbard asked earlier, the reason we don't look at the vertebral veins is that it's just such a complicated, tiny network that we can inject them and see them with venography, but it's pretty hard to treat them definitively or at least successfully. So generally what we're doing in treating CCSVI is treating the low-hanging fruit. We have equipment that can get into these big structures and that can fix those big structures, but it's a lot harder to get into tiny little veins up in the cerebral hemisphere. And so right now we're sort of treating the easiest part of the disease process that we can. Screening for CCSVI, Dr. Date again talked about this before. The main options are MRI, MRV, which gives you these nice images, which we love because it gives us a map and allows us to see exactly where we're going with our catheters and navigate through the system. Venous anatomy is notoriously variable. Some people have a large jugular vein on one side and very small on the other side. Some people are symmetric, but it helps in localizing where we're going. And the MRV image, as well as Dr. Hickey's protocol, helps us identify areas where we will want to treat. And so it's not always obvious just looking at the MRV. Sometimes Dr. Hickey's flow analysis helps us identify potential areas that we may look at more closely than others. The Zamboni protocol, again, discussed multiple times today. There's a lot of issues with it in terms of it being a difficult procedure to perform by a technologist. It's difficult to reproduce, it's difficult to teach people, and I think my personal opinion is that the MRV does a better job at evaluating the veins prior to having the procedure performed. Indications for CCSVI, controversial, as is just about everything with CCSVI. But generally speaking, we're treating patients with multiple sclerosis that have flow abnormalities on an MRV. We're also treating occasionally patients that have a positive Zamboni ultrasound, and we've treated a handful of patients who have had other neurologic diseases, such as Ehlers-Danlos syndrome and Parkinson's disease. The technique, you need a fluoroscopy suite with real-time X-ray evaluation. We puncture the common femoral vein in the groin with an 18-gauge needle. We put an 8-French sheath, which is a fairly large sheath to accommodate fairly large balloons. Most of the procedures can be done with very simple equipment. An angled catheter, looks like a hockey stick, that goes over a wire, and that allows us to select the azygous vein, the pelvic veins, the internal jugular veins on both sides. Sometimes due to anatomic differences, we may need a reverse curved catheter that sort of hooks around backwards, or a cobra catheter that has kind of a cobra shape to it. Once we advance a wire into the vein, we advance an angiographic balloon, usually a 0.035 system, which is sort of the standard interventional platform. The balloons are usually in the range of 5 millimeters to 18 millimeters in size. Rarely with lesions in the upper jugular or low azygos, we'll have to use an O&8 system, which is a more delicate system to get into smaller vessels. If lesions don't respond to balloons due to non-compliance, sometimes we'll use cutting balloons that have little blades on the balloons that will actually score the inside of the vein and allow us to open veins that might not open just with a regular balloon. And we do use stents occasionally on the order of 6 to 20 millimeters in size for unfavorable angioplasty results in certain patients. Just some images showing what the equipment looks like. The standard portable fluoroscopy machine that shoots x-rays to the patient. It's recorded on the image intensifier and goes and creates a radiographic image on the screen. This is the catheter that we use probably 90% of the time. It's kind of a workhorse catheter, various other shapes of catheters. The balloons come in all sorts of sizes and shapes, as do the stents. The technique, we use IV conscious sedation, usually with fentanyl and Versed to make the procedure